Hello, everyone. I'm Mark Friedman. I'm a professor of medicine in the field of neurology at the University of Ottawa and a senior scientist at the Ottawa Hospital Research Institute in Ottawa, Ontario, Canada. And I am joined today by my colleague, Roz Kalb, who I will get to introduce herself to you in a moment. And we're going to discuss an important issue about improving long-term outcomes in patients with relapsing MS and how to identify such patients at the earliest stage for optimizing treatments. Roz?
Hello, everyone. I am Rosalind Kalb, a clinical psychologist. I live in the state of Maine. I've worked in the field of MS in many different capacities, but I'm now a senior programs consultant with an organization called Can Do Multiple Sclerosis.
Well, Roz, it's been a long journey over the last, I'm going to say 30 plus years, where we had absolutely nothing for MS when I moved to Ottawa from McGill in Montreal. If someone asked me what patients looked like in Ottawa, they were all in wheelchairs, or had significant disabilities, because anybody with an earlier form of MS didn't need the MS clinics. There were no meds. There was nothing to offer them. And I think things have changed immensely in the last 30 years, where we've now got a whole tool chest of medicines that we can offer our patients. But there's something that's always troubled us, in that by the time the patient actually presents with their first symptoms that are suggestive of multiple sclerosis, we're well aware that something's been brewing for a while. I think studies have shown us that kids have started to deteriorate in their schooling, and there are underlying cognitive problems. Now we have this whole kind of prodrome. I don't know if you're aware of the so-called MS prodrome, which has so many non-specific symptoms, but a lot of the prodrome deals with some of the psychosocial problems that are then accentuated after the patient's been finally given the label of multiple sclerosis. What do you think about this prodrome? Are we getting to it early enough? Is there some way of identifying these patients before they ever actually present with their first, say, neurological symptoms?
I think it's a really important issue, and I don't think for many people that we are getting to it early enough. We know that mood changes and cognitive changes, for example, are actually hardwired into the disease for many people, which means that they can be among the first symptoms for a person with MS, long before any visible symptoms may happen that their family members may notice or that they may notice. So I think we need to listen to patients very carefully when they would begin to report odd changes in their mood or in their cognition that are impacting daily life. They tend to get poo-pooed, particularly if they are women. And so I think we need to listen and begin to do early screening of those symptoms, which can have such an important impact on daily life.
Well, mood problems probably are, I'm going to say, 100 or 1,000 times more common than multiple sclerosis. And if we start saying things like, as soon as the patient's feeling a little depressed, we should order an MRI, then we're going to be in trouble. But in honesty, a lot of neurologists are seeing patients whose family doctors are overwhelmed with a multitude of symptoms these patients have. They can't explain them. They don't have the classic features of, say, a first episode of multiple sclerosis. They order an MRI, and lo and behold, voila, there are lesions that look exactly like they are MS in this whole RIS field of radiological isolated syndrome. But these patients are troubled by all sorts of other factors. Now, what do we do with RIS patients? You must see those.
So I think it's given the state of our healthcare system, that's a very challenging question to answer. But for example, if you have a patient who presents with a significant depressive episode with no history, individual or family history of depression, we now know that that can be a first episode of multiple sclerosis. So I think it's where shared decision making actually has to start. We have to listen very carefully to what patients are saying. If they come in and a mood change has come out of the blue, and it's accompanied by severe fatigue, or it's accompanied by changes in the workplace, or a support partner or family member says, something's going on, this is not the same person I know, we need to find out what's going on. It may be worth doing an MRI on that person. So it takes patience on your part as a neurologist, careful discernment about what's going on to evaluate how we use our healthcare resources.
Yeah, it's hard because we have these criteria, and unfortunately, depression or cognitive change early on, which we know is characteristic of MS, can't allow you to make a diagnosis, and then without the diagnosis, you can't get the coverage for the disease-modifying treatments we would like to start early. But that doesn't mean we can't start addressing some of the symptoms that they're having with in the back of our mind. If we've done the MRI and we're already suspicious that these patients are going to develop MS, we just offer them, the follow-up that a neurologist can do to ensure that we're picking up silent disease, but having a psychosocial person to deal with the issues and treat them, I think would go a long way for these patients, don't you?
Well, when I first started working MS, which was in the 80s, before there were DMTs, I was at a comprehensive MS center. And what was interesting was that we didn't have DMTs to offer. So what we had the time and luxury to do was to treat cognitive changes, mood changes, use rehabilitation strategies, active symptom management, much of which gets lost today because there simply isn't time with all of the focus on MRIs and decisions around DMT. So I totally agree with you that we may not be able to start a DMT as quickly as we want until the actual diagnosis is confirmed, but there's no reason why we can't do those other interventions to improve quality of life and relieve symptoms.
Yeah, and I have to stress to patients because they keep thinking that the DMT that we're offering to change the natural course of their disease is going to really address all the other symptoms they're having, and they don't. Very few of them have a dramatic effect on cognition, and none of them, as far as I know, will help mood changes. These are treated the same whether you have MS or you don't, and so you can't just sort of say, okay, well, there's no option for you. You have maybe the prodrome of MS. You haven't quite got the diagnosis. And at that point, a lot of the neurologists would wash their hands of the patient, not realizing that they have something to offer them. If we could bring in someone to address some of the other concerns that they're having, because these affect their ability to be in the family and work comfortably and be able to deal with the other challenges of their life. It would be great to have someone like you, Roz, at our clinic. The Canadian healthcare system doesn't allow it, but I think this is an important asset to all multidisciplinary MS care centers.
We know that fatigue and cognitive changes are the primary reasons people with MS leave the workforce early. And so I think when people start to notice, or their family members notice, any change in the person's ability to keep up with conversations, remember things, focus their attention, make sound decisions, whether they've met the criteria for a diagnosis of MS or not, the sooner we intervene, the longer they may have the ability, hopefully forever, to stay working in their chosen field. So absolutely, we want to get started as early as possible.
So that's a really, important topic that we've covered today for our listeners. The whole notion of the MS prodrome and the role of DMTs is, that the DMTs are addressing the course of disease, but these other symptoms can be the most disabling features of MS. And if they are identified and addressed early, then the best outcomes in the long term can be held. Thanks so much for your listening today. Hello, everyone. I am Mark Friedman. I'm a professor of medicine in the field of neurology at the University of Ottawa and a senior scientist at the Ottawa Hospital Research Institute in Ottawa, Ontario, Canada. And I am joined by two of my American colleagues to discuss an important topic about how to manage the relapsing forms of MS and what the role of oral DMTs are in improving patient outcomes. I have two colleagues, Amy Perrin-Ross, a neuroscience nurse, and Roz Kalb, a clinical psychologist, and I'll let them both introduce themselves to you. Amy?
Hi, everybody. Thanks for joining us. I'm Amy Perrin-Ross, an advanced practice clinician at Loyola University Medical Center in Maywood, Illinois, in the U.S.
And Roz.
And I'm Rosalind Kalb, clinical psychologist, speaking to you from Maine. I am a senior programs consultant with Can Do Multiple Sclerosis.
Wonderful. Best way to start this would be to talk about a case. I think this makes sense to all of us when we are referring to a certain type of patient. So here's a typical patient, a 40-year-old woman, 6 years into her MS since symptom onset, but only 3 years since diagnosis. Her EDSS is not 0, it's 2.5, and she's been on a first-line treatment since diagnosis and hasn't really experienced any sort of clinical breakthrough disease in terms of relapse. Her MRIs have been stable. Her neurological examination has been stable, but she's started to have some problems keeping up with conversations and starting to express some fatigue about the injections that she's using and wondering where the benefit lies, as often happens after a few years of using these injectables. So one of the questions comes up, is there an alternative, and how can really the oral drugs now help us in terms of, I guess, controlling their disease and addressing the outcomes that we're interested in? Amy, what's your thought on the orals? You've been there through the injectables and now the orals. Where have you seen them really play a good role?
Well, Mark, I think that as you and I and others have started when we had only the injectables, we all looked forward to the orals and thought that they would completely replace all types of therapy, which in fact they haven't. But the rise of the use of orals, it has been incredible. We have multiple different orals available to us. And the nice things is that there are now orals with various different types of mechanisms of action, so that if one mechanism of action isn't working for a patient in terms of clinical or MRI stability, there are other orals with other mechanisms of action. Now, we've got the S1P receptor modulators, both the first as well as some of the second generation modulators. And I think even with some of the second generation S1P receptor modulators, we've seen included in their clinical trials cognitive measures. And of note with our case study, she's talking about the fact that she's having difficulty keeping up with conversation. And it's my experience that if people are recognizing this in themselves, they probably have far more in the way of cognitive impairment than what they're talking about. We also have things like the fumarates, we have teriflunomide, we have cladribine. So there are lots of different oral options, and I think I would definitely in this case move towards an oral option. I mean, she's telling us that she's tired of injecting, and that tells me, first of all, either she's already started skipping some injections, or if she hasn't, she probably will in the future. And we all know that if the patients don't take their medication as prescribed, we can't expect that clinical and MRI stability. So let's look to an oral for her, because those, in my mind, are really good options.
So I know I've been different parts of the world where people are quite skeptical of oral agents, and if it's not in something that could be injected, they don't believe that it will have any benefit. But the problem, as you know, when we're treating these patients is they don't see the benefit of the pill or the injection when they're actually taking it, because it's not addressing some of the things that they're really concerned about, their other symptoms. And so, what are other factors that we have to take into effect here when we're trying to get these patients to believe in their therapy? Roz, you must see some patients and have some of these challenges to deal with.
I think that the message that I have used over the years that's had the biggest impact is to compare taking a DMT to having life insurance or accident insurance. You are investing in the future. You may not see the benefit right now. We're asking you to take that on faith, but you are investing in the future, which we know from long experience can be seriously impacted by disease progression. And we have ample data today to show that early and ongoing treatment delays or slows progression and reduces the overall impact. I think Amy and Mark, you and I can all agree that the face of the MS patient today is very different than it was when we all started in our careers in MS and there were no medications available. So we are asking them to take it on faith and invest in their futures.
Yeah, when they don't see the immediate benefit from things, it's really hard to encourage their continued use, and that's the challenge, and we have to look at them holistically and reach out to others like yourself, Roz, and other people who are part of our multidisciplinary team to help deal with some of those issues.
I think the other answer, Mark, was related to what you're just saying now, and that is, if the very short time that a person has with a neurologist is spent only on looking at the MRI and talking about the DMT role in care, we're missing an opportunity to say, we know that these medications don't help with your current symptoms and everyday problems. So we need to focus on those as well and get you rehabilitation interventions to work on those. We need to talk about the symptoms that are impacting your life the most so we can manage those symptoms while you are also taking your disease modifying therapy. So it has to be a package deal, and they have to believe in our multidisciplinary commitment to helping them feel better today while they're investing in their tomorrow.
And Roz, you bring up an excellent point. DMTs are not meant to treat symptoms, and I reiterate that every time I talk to patients. And despite the fact that a person is on a DMT, they may still have symptoms, ongoing symptoms, for example. And one of the things that I often get phone calls about or discussions in the office is the difference between symptoms and side effects for these various different medications. And, I based on the type of medication, whether it's an S1P or fumarates or any of the other medications, I talk to them about what the side effects are, and we talk about, and very early on, focus on side effect management so that doesn't become so cumbersome that they want to give up on a therapy very, very early, especially because, as Mark said, and you as well, people don't see the immediate benefit of the therapy, but we try to reinforce that as we look at MRIs over time. And again, bringing in the whole cognitive aspect. If we are enabling these patients by keeping their MS stable with the DMT, enabling them to continue to work, to continue to be productive members of their family to parent their children and the other kinds of things that are important to them, that's very much an outcome measure that we need to help them recognize.
Those are excellent points you both brought up. I think that the patient today is very different than what we saw at the beginning. Patients were grateful to have anything. You gave them a needle. It could be this long. It didn't matter. They would take it. They were anxious to have a treatment. And today we have so many different options available to them. Although it's never a free lunch with the orals, there are some issues with them as well. They are a little bit easier on the body than the injectables, and that may help with adherence. It may help address some of the other symptoms, as we've learned about some of these drugs having an effect on cognition. So thank you both for bringing up these excellent points, and thank you to our listeners for tuning in. Hello, everyone. I'm Mark Friedman. I'm a professor of medicine in the field of neurology at the University of Ottawa and a senior scientist at the Ottawa Hospital Research Institute in Ottawa, Ontario, Canada. And I'm joined today by three associates who will help us in a discussion on cognitive dysfunction in relapsing MS, in particular, how to monitor and manage associated symptoms in our patients. I'm going to let my colleagues introduce themselves. We have Professor Dawn Langdon, Amy Perrin-Ross, and Roz Kalb. Dawn?
Hello, I'm Dawn Langdon, and I'm Professor of Neuropsychology at Royal Hospital, University of London in the UK.
Amy?
Hello, everyone. I'm Amy Perrin-Ross, Neuroscience APN at Loyola University Medical Center in Maywood, Illinois.
And Roz?
Hello, everyone. I'm a clinical psychologist, worked in a variety of settings in MS care, but I currently live in Maine and work with an organization called Can Do Multiple Sclerosis.
Wonderful. Thank you all for joining us today. Cognition is such an important issue in multiple sclerosis today, and recognizing it, assessing it, and managing it are really important to us all. And we have some insights on really a few things about this. And so I thought maybe we should start to talk about some of the cognitive symptoms that are associated with them. And then, we'll work into potential for treatment. So for cognitive symptoms, Amy, is this a common problem for you? And how challenging is this for you as a nurse?
Yes, cognitive symptoms are far more common, I think, than even 10 or 15 years ago we anticipated. People have a lot more insight, I think, today into their own cognitive functioning, and they will often bring these issues to us. But sometimes it's the family members and care partners who tell us that things are not quite right. Perhaps judgment is off, insight may be lacking in certain areas. So it's really not just memory, as people often think of with cognitive issues. It's often many more of the other kinds of activities, such as being able to pay attention for prolonged periods of time.
That can be a challenge to you, and it may well be something that you're comfortable talking about, but when would you reach out to our colleagues to try to get a little bit more, I guess, in-depth analysis of them? Because often this can affect their ability to work, and they're not sure if they can handle the same job. So we want to probably send them to specialists. When would you do that?
Well, we like to do that early on in the course of their disease, even before they have any experiences with cognitive dysfunction, because we like to get a baseline from our neuropsychologists to figure out where we're starting from. Often what we're seeing, particularly early on in the disease, is very much related to depression and anxiety with just a new diagnosis of MS. So we like to tease that out when we can. And then certainly as people live their lives with MS, we may do subsequent referrals so that the neuropsychologist can identify some of the neurocognitive domains that may be worsening in our patients. And that's really very important in terms of being able to work or being eligible for something such as disability payments from the government.
So Don, now you're going to get a referral from someone like Amy, and obviously setting everybody up for a 2-day in-depth neuropsychological exam is just not feasible today. What's your approach to these patients? How do you decide where to go, how to assess them, and who needs a quick one and who needs the more in-depth analysis?
So I think the most important thing is to listen carefully to the referrer, and if it's someone as expert as Amy, we're very lucky because that gets us off to a racing start. And it's very important to discuss fully with the patient what their experiences are, but to hold in mind that cognitive self-report for people with MS does not align to objective cognitive scores. Really, it's about their experience and may be coloured by depression and other psychosocial aspects. So it may be that we need to think about triaging cognition, mood, and fatigue to try and identify exactly what the alchemy is of the patient experience and impact. And also, whenever possible, I would speak to the carer, because we know from quite robust research that carers and relatives, informants of people with MS, are able to give a more accurate picture in terms of objective assessment than the patient themselves. So having got all that information together, I would also try and think about what the risks to this patient are. So we know that cognitive impairment affects disease management, employment prospects, driving safety, and participation generally. And so I would always want to have an MSNQ, which is a self-report measure which tells us what the patient's full experience is, and there's also a relatives version. I would want to have an SDMT, which is a 5-minute information processing speed measure. I would want to have a quick measure of mood and fatigue, so it could be the HADS, could be the FSSS. And then there's BICAMS, which is a 15-minute assessment, including the SDMT, includes verbal memory and visual memory. We know that it's as good in psychometric terms as the 90-minute gold standard McFIMS, which is much more expensive in terms of materials and time. And I would suggest that that is a good starting point to help understand what the patient's cognitive status is.
Well, I guess it would be wonderful if we had medications that addressed directly the cognitive problems that our patients have. But as you've heard, it's quite complex and often interactive with mood and other features. Some of the DMTs that have been used have been looked at testing of cognitive function, and we've seen some benefit in some of the products, but not all have shown an impact that is significant. We've seen some significance with some of the newer drugs like ozanimod and siponimod, where they've done cognitive assessments a little bit more in depth. But as you've alluded to, there's a lot more to treating some of the cognitive dysfunction and the impact it has on patients and their families. And that brings to mind, I guess, some of the psychosocial issues that these patients have, which really they have problems with the cognition interfering with their integration into their job, society, and family. What sort of challenges do you see, Roz?
Well, I think my colleagues have alluded to many of them. So I just want to reinforce that we have ample data that at the time of diagnosis, a significant people with MS are already experiencing cognitive changes that may not rise to the level of their awareness or even their partner's awareness, but they're there. So that screening for cognitive changes and, as Dawn said, mood changes early on is critically important. Within 7 years, a person who shows cognitive change at the time of diagnosis will already experience work changes or a loss of their place in the workforce. 7 years. So I think the earlier that we can intervene, treat any depressive or anxiety symptoms that are impacting cognition, the sooner we can help people get on their feet and maintain control of their work lives, their family lives. I also spend a lot of time in my work with carers, or as we call them, support partners. And I know that the slowing of information processing, problems with attention, problems with memory, are very puzzling and distressing to partners because conversations are impaired, relationships are affected. So I just can't emphasize I can't emphasize enough how the early assessment of these changes can help our patients in every aspect of their lives.
Just in the end here, we've talked and touched on some of the DMTs having some effect, but there are some medications out there that I don't think are terribly impressive in their effect on cognition. Don, are there some non-pharmaceutical interventions? We see this stuff all over the internet, train your brain, neuroplasticity. Everybody's trying to sell you some, variant of Sudoku to, train your brain and improve it. What do you think of these non-pharmaceutical interventions?
So there are many quite convincing, well-designed studies that show that computer retraining of particular cognitive domains does raise the person's performance in that particular domain. And they're relatively cheap to do. We've done a study where people have followed a self-directed program at home 3 times a week for 45 minutes. We got over 70% compliance. So it's in their favor. They're relatively easy to deliver. What we don't know is how far they impact on a person's life. So in terms of everyday function, how much of an improvement is there? It is likely that cognitive tasks, which are quite demanding, may offer some kind of protection against the onslaught of multiple sclerosis pathology on cognitive function. And that is the hypothesis of cognitive reserve. So there's quite a lot to be said for people with MS following some kind of stretching, demanding mental activity on a regular basis. And it may be that some kind of computer cognitive retraining is the easiest way for them to achieve that.
Well, I think we've touched on a lot of important points here on addressing some of the cognitive symptoms that patients have, our approach to analyzing them and possibly even treating them. And thank you for tuning in today.